Dear students, welcome to CQR or Cedees quick review. Now, this will be an attempt to go through what we've already learned in a very fast manner, which is going to help you just before your NEET or INI-CET exam. This is not an attempt by me to teach you the topic, but just to review the most important things. So you should be able to do the topic in probably in less than 10 minutes. That is the basic intention, but filled with knowledge. So even if you think you know Scalp and Scalp is very easy, this is the first topic that we learned when we entered our first BDS. Well, after the session, I would like you to rethink the same statement again. Okay, so let's try to understand the scalp. First of all, when you see the scalp, what exactly is the scalp, right? The scalp is a covering, right, all over your cranium, right, covering the cranial vault. So as can be seen here, you can see there's so many layers of the scalp, which is right from just above the eyes all the way till the external occipital protuberance is where you have your scalp. And the first thing that we also learned during our BDS days was scalp is very easy to learn, or anatomy is very easy to learn. There are mnemonics, there are diagrams, padlo, isn't it? That is how we were taught. And then we understood what anatomy was slowly as they started entering deeper into the subject, right? Okay, now more about that as we go on. Now let's look into the extent of the scalp. Now anteriorly it extends from the supraorbital margin. It goes all the way backwards, posteriorly until the external occipital protuberance and the superior nuchal lines. I will show you in a skull in the next line. On each side, it extends up to the zygomatic arch and the temporal lines. So it's easy to understand. Let's see this here again. Now these is the supraorbital margins. So the extension is from there, it goes all the way till here, your external occipital protuberance and your nuchal lines, okay? And of course, laterally towards your zygomatic arch or your temporal line. So the whole of this is like a helmet, which is there over your cranial vault. Now that is your scalp, right? Okay. Now this is what we have definitely learned. Yes, CALP. It's not easier here, So S stands for skin. C stands for connective tissue. I would like you to see the diagram and see that there is red and green and blue and all different colors, basically to emphasize that that is the area which is highly vascular. Okay, very, very highly vascular, right? And this connective tissue, you can also remember it as the dense connective tissue. There is another connective tissue down, which is the loose connective tissue or the loose areolar tissue. So this can be remembered as the dense connective tissue, which is very highly vascular and innervated. So vascularity, please remember that. The third one is the least understood, right? Whenever there are MCQs on aponeurosis, it definitely goes for a toss. And I've seen that whenever MCQs come, whether on the occipitalis or frontalis or the aponeurotica, we don't know. So let's try to understand that they all look very simple. It's just disguised like that. But let's try to understand this a little more in depth, okay? Then the fourth layer is the loose connective tissue or the loose areolar tissue. You all know it's also known as the danger area. And the last layer is a pericranium. So if this is the skull, the thin layer which is just covering that is what is called as your pericranium, right? All the five layers, you're good. Let's move on. So you've learned the extent. Now you learned what SCALP stands for. Let's start with each of them. Skin, easiest to understand. It's filled with hair follicles, most important area for the sebaceous cyst. Not very important for us anatomically. Not many questions come from there, but that's the first layer. The second layer is known as your subcutaneous tissue. Now, as I mentioned to you, you should remember it as the dense connective tissue. It's also called the superficial fascia. And if you see the diagram here, you will find that it's loaded with blood vessels. So vascularity is the single most important thing of this layer. Okay, so please do remember that. Another point is that the blood vessels in this layer, what happens, my dear students, is that you have the skin on the top and you have the galea aponeurotica, or basically your aponeurosis there. Okay, so this layer or the dense connective tissue, I remember the word dense because it's very, very fibrous, right? There are a lot of fibers moving across from the skin to your aponeurotica. And it is between these fibers that you have these blood vessels trying to move through. And that is the reason whenever there is an injury, so usually whenever there is an injury throughout the body, the vessels will retract and there can be a reduction in the bleeding. Yahan pe what happens is their blood vessels cannot retract, and that's the reason why there is a tremendous amount of bleeding. Okay, so the blood vessels within the layer are highly adherent to the connective tissue. Remember the word dense, very fibrous, and this renders them unable to constrict fully, if lacerated, and that is why the scalp there is profuse bleeding. It has a very rich vascular supply, so it heals well. At the same time, because of its very rich vascular supply, there is also a tendency for excessive bleeding, and the reason is how the vessels are attached to your fibers. Okay, done. The third layer, right now, this is something which you should really focus on. This is what we know as the epicranial aponeurosis. Now, when you say aponeurosis, what do you mean by aponeurosis? Aponeurosis is like a tendon, it's like a sheet. Okay, so if you see this here, it's a thin tendinous structure that provides an insertion for the occipitofrontalis muscle. Now, what you should understand is the third layer consists of two muscles. Okay, so you have a muscle in the front. How do I put that? Okay, so you have a muscle in the front called the frontalis. You have a muscle in the back side called occipitalis, and then you have this aponeurotic sheet in the middle, as can be seen in the diagram there. So there are two muscles, frontalis, occipitalis, and the aponeurotica right in the middle. Okay. So this occipitofrontalis muscle is what is called as epicranius, right? And this is the aponeurosis, or like a fibrous sheet or a tendinous sheet, and when you join them together, you get what is called as epicranial aponeurosis, right? Okay, so yeah. So you have the frontal and the occipital bellies. Now this frontal belly, or the frontalis muscle, we have to learn the origin and insertion of the frontalis and the occipitalis. I'll come to it in the next line, but please understand this. The frontal belly raises the eyebrows like this. Raise the eyebrows as well as the wrinkling of your forehead is because of this frontalis muscle and how it is inserted towards your orbicalis oculi and all of that. Okay. Whereas your occipitalis, on the other hand, is responsible for the retraction of your scalp. So please understand the third layer consists of two muscles and the galea aponeurotica, or basically this aponeurotic sheet, which is in the middle. So if you look at this diagram, I think it'll stay in your mind. Okay, let's move on. So let's look at the frontalis muscle. If you look at the frontalis muscle, my dear students, the origin of frontalis muscle. See, this, as I mentioned before, let's assume this to be the frontalis, this to be your occipitalis, this is your galea aponeurotica. Now look at the origin and insertion. The origin of frontalis is from the epicranial aponeurosis, and the insertion, is towards your skin of the eyebrow and the muscles of your forehead, basically your eyebrow. There is no bony attachment, right? But the origin is from your epicranial aponeurosis, and the action is to elevate the eyebrows and pulls the scalp anteriorly. You can see it in the diagram here. Okay, now let's come to occipitalis. On the other hand, the posterior. Now the occipitalis, the origin of occipitalis is from the bone. Basically, it originates from the lateral two-third of your superior nuchal line. Okay, lateral two-third of the superior nuchal line, and from there it extends upwards. It is inserted into your aponeurosis. So I'm hoping it's very clear. Frontalis originates from the epicranial aponeurosis, whereas occipitalis is inserted into your epicranial aponeurosis, and the function of it is to retract your scalp. Okay, so we have learned occipitalis, frontalis, galea aponeurotica. You learned that it is a sheet. It's like a fibrous sheet which is nicely covering over the skull in a very tight way, and that's the reason I told you that these three layers, the skin, your dense connective tissue, and your epicranial aponeurosis, all three can be considered as one layer. It's impossible to really separate them. Okay, right. And both of them, your occipitalis and frontalis, are supplied by the facial nerve. Frontalis is supplied by the temporal branch of facial nerve, whereas your occipitalis is supplied by your posterior auricular branch, again of the facial nerve. Okay, so I'm hoping that this is quite clear. Occipitalis, frontalis, galea aponeurotica, what is their origin, what is their insertion, what is their function, what is their nerve supply. So many MCQs just in the last 2 minutes discussion. Okay, right. Let's move on. So another way, just to highlight this, your occipitalis, your frontalis, and your epicranial aponeurosis. Clear? Now we go into the fourth layer, who's called as the danger area or the loose areolar tissue, right? Now, this is called the danger area. See what happens now. This area is very loose compared to your dense connective tissue, right? And this is also the layer where if you need to do this craniotomies or something and you need to remove this the scalp off, then this is the layer through which it is cut, right? It is called relatively avascular. I'm not saying that it is not vascular, but compared to your dense connective tissue, it is relatively avascular. Okay, loose sponge-like structure and all that, relatively avascular plane. It's very important. It's very ideal for your dissection. Okay, for craniotomies and all that. So please remember that. Okay, now the loose areolar tissue is called the danger area because you see these vessels here. Now these are what are called as your emissary veins. Emissary veins. Now these emissary veins, so you have the emissary veins, you have the diploic veins and all of that, but these emissary veins are valveless, means they can allow bidirectional flow of blood. And what do? They connect your extracranial veins, veins which are lying outside your cranium, to your intracranial venous sinuses. See the way it is coming down. Okay, and it is your loose areolar tissue which basically houses this entire emissary veins, which is moving from the outside to the inside. So you can imagine any infection from the outside of the scalp can go straight down into your intracranial venous sinuses because of these emissary veins. The emissary veins have a lot of important functions, but for us, the infection becomes a big problem. That's why it's also called the danger area. Please understand that. Please read this line. It's a sponge-like layer that allows the scalp proper to glide over the pericranium. Okay, it's a sponge-like layer. It just helps things to move. What you should understand is that the first three layers are almost intimately binded together. Even though we call them as first layer, second layer, you cannot really separate them. So when you try separating them, all these three layers will come as one layer, and then you lose areolar tissue. That is where you cut across, and then you have the pericranium at the bottom. Okay, so let's move on. This is why this is called the danger area, because of the presence of emissary veins. I'll come to this a little later when I'm covering the venous system. Okay, right, and then you have the pericranium, right? Very innocent looking, small covering over your skull. Now, the pericranium is the deepest layer of the scalp. Okay, what you should understand is that it is very loosely attached. Why do they say the word loosely? Because whenever there is, let's say, an injury or something, blood can easily collect between your pericranium and the bone below. But it is very firmly attached at the sutures. So wherever you have these sutures now, it is very, very firmly attached. Okay, so whenever there is a collection of blood here between the periosteum and the skull, it'll lift up the periosteum here, but it will never lift up your sutures. Why is sir insisting on that? Simply because you have a condition called a cephalohematoma, which is seen in infants when you're trying during their delivery. If there is a vacuum or forceps extract, kind of delivery is being done because of some injury, there can be collection of blood between the periosteum and the bone below, which is called as cephalohematoma. But one very important feature is whatever happens, the collection of blood will never cross the suture line. Why? Because the periosteum is very, very firmly bound to the sutures. Okay, so this is your cephalohematoma. I'd like you to read this small paragraph here. It's strictly limited to the shape of the underlying single bone. He's talking of the cephalohematoma. It physically cannot cross the suture lines because the cranium is tucked down. You can see how tightly it is tucked down there in your suture lines. So I'm hoping that this is quite clear to all of you. And this condition is called cephalohematoma. I'd like to discuss another clinical point here. Now there are two conditions. One is called as the caput succedaneum and the other one is called the cephalohematoma. If you were to keep your eyes closed, cephalohematoma is the one which is more dangerous. There is collection of blood. there is collection of blood between your periosteum and the underlying bone. Okay, I'm sure. Yeah, so I'm hoping that this is very clear. Where is the collection of blood in cephalohematoma? Between the periosteum, as seen in the last slide, between the periosteum and the underlying bone is what is called as cephalohematoma, right? Commonly caused by blood vessels that were damaged during labor and delivery, okay, because of very difficult delivery with forceps or vacuum extraction or things like that. And usually it you don't do anything much, but it lasts for like 6 months or 8 months. On the other hand, you have something called as the caput succedaneum. This is a very milder form, but here the collection of blood is above the periosteum and the skin, so that is where the collection is. It's basically serum and a little bit of blood and all that, but there's nothing to worry. Only the name is very scary, caput succedaneum, but otherwise it's a very mild thing. Okay, so please understand the difference here. In caput succedaneum, the collection of blood is above the periosteum and the skin, whereas in cephalohematoma it is below the periosteum and the skull. So that's where it comes. Okay, now here, caused by prolonged pressure being exerted on the baby's head during delivery by a dilated cervix or the vaginal walls, and again either using because of forceps use or extraction tools and all of that. Okay. Now here, a very important difference is it can extend across the suture lines. Why? A caput succedaneum can extend across the suture lines because it is not binded by the periosteum. A cephalohematoma can never cross the suture lines because you have your periosteum going deep down into your sutures, right? And you don't have to worry because it usually within a period of 48 hours or something, the child will be fine. Just that you'll have that lump there and slowly it will resolve and the body will take it off, right? So this is the difference. Caput succedaneum, not to worry. Cephalohematoma, also not to worry, but it resolves only after a period of 6 to 8 months. So that's a little, and this is blood. Cephalohematoma is blood. There could be injury to the underlying bone, whereas this is serosanguinous, means it's blood with serum and nothing much to worry, right? So I'm hoping you understood the difference between these two. Okay, right. So after that, we will move on. All of you. So what have we learned so far? We have learned about the extent of the scalp. We have learned what is S, what is C, what is A, what exactly is aponeurosis, occipitalis, frontalis, their nerve supply, their origin, insertion, loose areolar tissue. We've learned about the emissary veins, right? And how the surgical layer, I mean, all three come together. That is where the ideal plane of dissection is actually there. We learned about the periosteum. We learned about how it is actually loose but very tight at the sutures. And you have two different conditions called as cephalohematoma, and the other one is caput succedaneum. After you've done all this, let's move on to the arterial supply of the scalp. Okay. Now, the arterial supply is rich. It is, as I've said before, it is very highly vascular. It's supplied by both the ICA and the ECA, as can be seen in the diagram here. The ICA, you have branches of the supratrochlear and the supraorbital arteries, which are in turn branches of the ophthalmic artery, in turn a branch of your ICA. And you have your superficial temporal artery, which is a branch of your ECA. All of them are for the anterior. Posteriorly, we have the posterior auricular and the occipital arteries, branches of ECA. I'm hoping, my dear students, you remember. And if you remember the Cedees classes, it's the first thing that we do in anatomy. I see all the branches, right? The ECA, all the 8 branches, 3 anteriorly, 1 medial, 2 posterior, 2 terminal. You should know all this very well. Okay, I'm not teaching you now. This is just a quick review, but a detailed review. Please try to understand, right? So this is the anteriorly. The ICA has 2. That is your supraorbital, supratrochlear. Intern branches of ophthalmic artery, intern a branch of the ICA, right? Anteriorly, you also have superficial temporal, which is a branch of the ECA. Posteriorly, 2 blood supply, posterior auricular and occipital, both branches of the external carotid artery. Got it? So you've learned about the arterial supply. Okay, so I think this is just a simple tabular column. You can probably take a screenshot if needed, but I think it's very easy to remember. So just remember that these 2 are by the ICA and these 3 are by the ECA or the external carotid artery. So you've done the blood supply. Now, venous drainage. Most of us really don't know about the venous drainage of the scalp. Okay, let's do this a little bit in detail. Okay, another 3-4 minutes. The venous drainage of the scalp is actually divided into a superficial part and a deep part, right? The superficial part, which we all know very well because it continues down as the famous W arrangement of your face and all of that. So it's very easy to remember. So the superficial part or the superficial venous drainage of the scalp is mainly done by your supratrochlear veins, your supraorbital veins, your superficial temporal vein, and posteriorly we have the posterior auricular vein, you have your occipital vein. All of these 5 veins form sorry, not max, your superficial temporal vein. All of these 5 veins form what is called as your superficial venous drainage of the scalp. Okay, I have a small flow chart, so we'll just go through this superficial venous drainage of the scalp, right? So the anteriorly, what as can be seen here, we have supratrochlear and supraorbital veins. They drain the forehead and the anterior scalp. Okay, and then it comes down to form the angular vein, and it goes down to form the facial vein. I think that's pretty clear. Now, laterally, what do you have? Laterally, we have your superficial temporal vein. So, supratrochlear, supraorbital, anteriorly. Laterally, what do you have? You have your superficial temporal vein. My dear students, I'm going a little fast because it is CQR or a Cedees quick review. So, I'm hoping that you've done it, so it's easy to capture. You have a superficial temporal vein, which again will join the maxillary vein and forms the retromandibular vein. If you've seen the parotid, or if you are there in the classes during the parotid gland discussion, you know it's very easy, right, to understand the superficial temporal and the maxillary vein join to form your retromandibular. Well, that comes in the face, so we will not discuss today. The fourth and the fifth, posterolateral region, this one, posterolateral region, we have what is called as your posterior auricular vein, right? Your posterior auricular vein, which again comes down and joins the retromandibular vein, goes into your external jugular vein, right? And you have your occipital vein, which drains the posterior part of the back of the scalp and terminates into your suboccipital plexus of veins, or sometimes into your IGV. So this is the superficial venous system. Let me repeat again. Supratrochlear, supraorbital, superficial temporal, posterior auricular, and occipital. If you've learned these and you remember this a little bit, you've done your superficial venous drainage of the scalp. Now we're going into the deep. Now when you go into the deep, you have the first line here. The deep parts of the scalp, particularly in the temporal region, they are drained into what is called as your pterygoid venous plexus. Now we know that very well, right? When we learned about the cavernous sinus, we discussed about your pterygoid venous plexus. So the deep parts of the scalp, particularly in the temporal region, are drained by the pterygoid venous plexus. Okay, so this is a deep venous drainage. Now we have two other very important parts of the deep venous drainage. One is your emissary veins, and the other one is called as your diploic veins. Okay, now emissary veins, I have had a small discussion, so let me discuss about the diploic veins. See, diploic veins means, let's assume that let's assume that this is your skull. Okay, so you have the outer table and the inner table. So the middle portion, the cancellous portion, there is what is called as a diploic, and the veins that drain in that middle portion is what are called as the diploic veins. Okay, so let's see this. What are the diploic veins? They drain the blood from the space within the bone and it takes it into the dural venous sinus. So these horizontal veins that can be seen here, present in the cancellous part of your skull there, okay, is, and then they can be connected to the emissary. They can move into your intracranial durovenous sinuses. They're called the diploic veins. And the other one, of course, is your emissary veins. Now, if you look at the emissary veins, how you see from the outside, it comes straight inside, it penetrates through the bone, through the bone, okay, and then it comes into your intracranial venous sinuses. So from the outside, suppose let's take this. So from the outside, goes through everything, okay, goes through your loose areolar tissue, that's where they're majorly located, penetrates and hits across the bone and then goes into the intracranial venous sinuses. And that is why they're called as your emissary veins. They're valveless. They can spread the infection both the sides. Very, 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 very dangerous. It has good functions, but the infection predominates, right? It drains the blood from the external surface into the skull of into the dural venous sinuses. So when you see the deep part of the deep venous drainage of the scalp, remember the pterygoid venous plexus. Remember the emissary veins. Remember the diploic veins. Okay, right. So let's do this again. So what you see here, this whole thing is your valveless emissary veins. What can be seen? They connect the extracranial into the intracranial venous sinuses. They help in equalizing the pressure. If there's too much pressure inside the cranium, they can flush it outside, right? Risk, as I've said to you before, bidirectional. So chance of infection going straight down is very, very high. Now we have diploic veins. We discussed the small channels within the bone. There are four major diploic veins. Very easy to remember. The first one, frontal. Okay, here. The second one, anterior temporal. Here. The third one, posterior temporal. Here. And the last one, occipital. Right? So what do we have? Right in the front, the frontal, anterior temporal, posterior temporal, and occipital. So these are four areas where you have the diploic veins. Okay? The frontal, it opens into the supraorbital vein. Not that important, but please remember that there are four diploic veins. Okay? Anterior temporal goes to the deep temporal vein. Posterior temporal ends in the transverse sinus, very important. Occipital either opens into the occipital vein or into the transverse sinus. Right? So there are four diploic veins: the frontal, anterior temporal, posterior temporal, and occipital. Got this, all of you? So all these three come under what is called as your deep venous drainage of your scalp. I still have to cover. Okay. When it comes to emissary, there are two main emissary veins to remember as given in your Chaurasia textbook. Okay. Also, of course, in Vishram Singh and other books. Two ones. One is the parietal emissary vein and the other one is the mastoid emissary vein. As can be seen here, this is the parietal emissary vein, and look at the structure here. This is nothing but your superior sagittal sinus. So the parietal emissary vein, it connects the superficial temporal veins to superior sagittal sinus. Not very important, but please note that the most important emissary channels are the parietal emissary vein and the mastoid emissary vein. Here, the mastoid emissary vein, and that takes it into the sigmoid sinus. This may be a little high for some of you, so let me just recap this. Diploid, there are four veins. Okay, what are the four veins? As can be seen in the diagram here, easy. Frontal ho gaya, anterior temporal, posterior temporal, and you have your occipital. These are four diploid veins. Okay, and when it comes to the emissary veins, you know what they are? There are two major emissary channels. One is your parietal emissary vein going straight into your superior sagittal sinus, and the other one is the mastoid emissary vein, which is going into your sigmoid sinus. Okay, so please understand this key emissary channels. What are the diploids? So if you have done all of this, that means you have gone through, my dear students, your we have learned the arterial supply. It was very easy. The venous, it can be divided into superficial and deep. So understand what are emissary, understand what are diploid veins. Next, we move on to your lymphatic drainage. Easy. The entire anterior scalp, forehead and the frontal region and everything, this entire thing is draining into what is called as your preauricular or your parotid lymph nodes. Right now, just above the ear, right, lateral scalp, that's above the ear, that also will drain into your preauricular nodes, but otherwise that's not very important. The one which is most important is the other part, the posterior lateral part of the scalp is entirely draining into what is called as your posterior auricular or your mastoid nodes. Okay, and the posterior part of the scalp, the entire posterior part of the scalp or the occipital part of the scalp, it drains into your occipital lymph nodes. Okay, and then of course subsequently into the deep cervical nodes. So that is easy. Anteriorly, you just remember the preauricular or the parotid nodes. Posterior lateral or the lateral part of the scalp, you can remember the posterior auricular or the mastoid. See, basically you have the parotid nodes, you have the mastoid nodes, and you have your occipital nodes. So if you remember these three, the lymphatic drainage of the scalp is done. Okay, so you can see the diagram here. Look at the preauricular lymph nodes or the parotid lymph nodes, and then you have your occipital lymph nodes over there and your posterior auricular lymph nodes over here. If you remember these three, I think your job is done. So we've done the entire thing of the scalp, right? We move on to the last part, the nerve supply of the scalp. Easy. This again can be divided as in the front and behind. So 5 in the front of the ear and 5 behind the ear. When you say 5, it is 4 sensory, 1 motor, 4 sensory, 1 motor. Okay? Right. So if you look into this particular diagram here, anteriorly you have, again, it's very easy because all the branches of the trigeminal nerve, 3 branches are there of the trigeminal nerve, ophthalmic, maxillary, mandibular. All the 3 are important for supplying a sensory supply in front of the auricle. What are they? Let's go through. The supratrochlear nerve, the supraorbital nerve, branches of the ophthalmic nerve. Okay? Then zygomaticotemporal nerve, a branch of your maxillary nerve. Auriculotemporal nerve, a branch of your mandibular nerve. So all the 3 parts of your trigeminal is covered. Ophthalmic, maxillary हो गया, mandibular हो गया. So supratrochlear, so you have the supratrochlear nerve, supraorbital nerve, zygomaticotemporal nerve, auriculotemporal nerve are all sensory in front of the auricle. Behind, so and then you have a one motor. The motor is going to be done by your temporal branch. As we learned right in the start, it supplies your frontalis muscle, the temporal branch. Okay. Now, I'm hoping that this is very clear. In front of the auricle, we have supratrochlear, supraorbital, zygomaticotemporal, auriculotemporal. The motor branch is the temporal branch. Now, behind the auricle, it's very easy to remember. You have what is called as the great auricular nerve, lesser occipital nerve, all from the cervical plexus, greater occipital nerve, and the third occipital nerve, right? Greater auricular, lesser occipital, the greater occipital, and third occipital. I'm sure you've learnt all this, my dear students. I'm just recapping it. I'm not teaching you. That's why the speed is a little more faster. Not the way I like to do, but it's a quick review. So, right? And then the motor supply is by the posterior auricular branch of your facial nerve. Okay? We have learned this right in the start. And that is mainly supplying your occipitalis muscle. So here we go. Greater auricular, lesser occipital, third occipital, greater occipital. And then your motor supply is by your posterior auricular branch. My dear students, so this completes your scalp, starting right from the extent, all the 5 layers of the scalp, your arterial supply, of course, your galia aponeurotic or epicranial aponeurosis, your venous drainage in detail, emissary veins, the 4 diploic veins, the 2 major emissary channels that you have, and then you've done your nerve supply. So this is the basic funda of scalp. It looks very easy, but I don't know if you knew all these points well. Okay, so just to recap your sensory nerve supply in front of the auricle, because this is the diagram we have in the book: supraorbital, supratrochlear, zygomaticotemporal, and auriculotemporal. Ophthalmic, this is from the maxillary, this is from your mandibular. And then you have your greater auricular, lesser occipital, greater occipital, and your third occipital nerves. Okay, right. So this is the summary of what we have learned so far. SCA. This is the first 3 layers are called the surgical layers, which is your skin, the dense connective tissue, and the aponeurosis. They're tightly bound together and they move together. Okay. Then we've learned about the loose areolar tissue, the blood supply, the venous drainage, nerve supply. Yeah, I think this is okay. We have learned about the loose areolar tissue and why is it called your danger area. You know? Right. So the last one, you can probably take a small pic and just keep it in your mind for your exams. The extent anteriorly, supraorbital margin, posteriorly all the way to the external occipital protuberance with the and your superior nuchal lines. On each side, we have the zygomatic arch. So this is the extent of your scalp. Layers, we have done this in detail, easy to remember. Arterial supply in front and behind. That also we have learned the ICA and the ECA, supraorbital, supratrochlear, superficial temporal in front. posterior auricular occipital behind. Nerve supply is what we have just learnt, right? And along with this, we have also gone through the important things about what is cephalohematoma, and we also learned about what is called as caput succedaneum. So I'm hoping that these points are right there. So this is about scalp, your CD's quick review. I'm sure that it'll help you. Thank you so much.